So we'll jump into part two. And I wanted to just take a little bit of time for what does this actually look like in practice? How do we develop those workflows? How do we really make sure that we are doing that risk assessment? And are we doing risk assessment on admission in the hospital, but then are we reevaluating that status, especially if, like Cheryl, like was mentioned during the question and answer, sorry about that, said, like we've got these patients who are now admitted in the hospital and they're there. So then their risk actually goes up and it changes. So really kind of thinking through what we have. And then I thought it would also be important to think about what are some of the nursing implications for VTE assessment and management. And then always critical is what does the patient education look like? What are we making sure that the patients are aware of so that they can advocate for themselves after they go home? Oh, I guess I had some pictures there. I don't know what that was supposed to be, but we will look at this. So I really wanted to, so I brought back up the algorithm from the first prenatal visit. And so what is recommended from CMQCC's standpoint is that this algorithm should be available in the outpatient office, that all of the office staff, so your check-in staff, if they have a patient who has, calls and says, well, I have a history of this and I need to get an appointment, that is flagged somehow, that your nursing staff and the provider staff, and there's really the highlight of those top three questions. Does the patient have a personal or family history of VTE? Does the patient have a personal history of a thrombophilia, or is the patient currently on anticoagulants? And so within that kind of established initial set of questions, then that should guide us into what other information do we need to get. And so this historically, when we've worked on safety bundles in South Carolina, we've really focused on what is happening in the hospital, in that clinical care in the hospital. But this piece, and this particular bundle especially, is very important that we're starting that assessment in the outpatient setting. And so that's a newer ask for, I think, our hospitals and our providers, really making sure that we're bringing this back to the attention of our staff in the OBGYN office where we're doing the prenatal care. And then how do you integrate this in? Who's doing the history? Who's doing that pregnancy management plan? And then, again, kind of looking to see, well, what was the cause of that VTE? If they had a history, was it related to a medication they were on? Had they had surgery on their leg? What was really the cause of that? And then really looking and thinking at, and I know everybody has to groan whenever there's a potential update to the EMR where we're asking for a build to put something in. But really kind of, do we have the ability to have it built in so that it flags you when you're seeing that patient to answer those questions or ask those questions and get them answered? And so I think my biggest point for the antepartum piece is that as a former antepartum nurse, you get those patients that I say used to move in with us. They were there with us. They had PPROM. They were, on mostly bed rest. Maybe they had bathroom privileges. They were able to maybe get up once a day to go shower. But they're there with us. And so what are we continuing to do? Are we remembering that when they've been here for 3 days, their risk is going to change, especially for the potential for clot formation? Or maybe now they have a new diagnosis added on, like a preeclampsia or something like that. So really kind of making sure that everybody is keeping aware of this. And then you start thinking, okay, well, where there's so many things that we have to keep aware of that you almost get kind of that alarm fatigue that could happen. But when we look at trying to prevent a DVT or trying to prevent a PE, this is really important. And this is why we do what we do. So how do we kind of automize that just a little bit so that there is some kind of flag that pops up and says, this patient's been here for 72 hours. Are there additional risk assessments that need to happen? That's just one thought. Or if that is the process for when your providers are rounding, or for nursing staff to say, hey, remember, she's been here for 3 days. We need to redo risk assessments. And really kind of working together as a team, I think, is the biggest goal here. like we said earlier, when you're developing workflows, when you decide to implement any kind of bundle, but really is we need to make sure that we have a workflow that works within the policies and procedures that you already have. And if those are not appropriate because they are out of date or they're old or the science has changed a little bit, we need to really make sure that we're updating our policies. There are really critical times with a cesarean patient. We always want to use those compression devices. We really want to make sure that we are remembering that risk assessment for prior to the C-section and then immediately postpartum, and what are those postpartum orders. And then that third time is when she's being discharged to home. So what kind of medication or prophylaxis does she need to be on, or what kind of additional follow-ups need to be there. And medicine used to be a little anti-checklist, but we have decided that, we can't always remember everything. So checklists can be a benefit to us because we have that clinical skill that it just triggers a reminder for us. And that's what I want checklists to be thought of when we're doing any quality work, is that the expectation is, yes, you are an expert in everything that you do, but we all have crazy days. We all have bad days, and we all kind of, in an emergency, sometimes forget some of those things and you remember later. So if there's a checklist that allows you to just be like, yep, I did it, just like the pilot who's going to take me home this afternoon. I want him to do that checklist every time. So what are we doing to set up to ensure that we are doing the best thing for our patients? The other piece of this really is involving not only anesthesia, but pharmacy in all of this work, because we're going to be asking for things and even supply, if you think about that, and needing to get your SCDs brought up to the floor if they're not already in every postpartum room. So, what kind of processes are in place, and then how do we all agree on, this is what we're all going to do every time for every patient. So just to touch a little bit, I did not look at the list of people who are participating today, but for the nursing implication, we do know that perinatal nurses do need to be knowledgeable and proficient in the assessment of risk factors. They are what we often consider as kind of the first line stop. So when you're doing admission, you have a set of questions that you're asking, and nursing is often sometimes the ones that are actually giving the medication, doing the treatment, doing the, following those physician order sets or those new orders that have been written in. And so we want to make sure, again, that we're doing wherever you are, inpatient or outpatient, that you are able to understand what is the risk for VTE, what is a DVT, what is a PE, what are those signs and symptoms, what are things that we need to be aware of, and what does it mean to be a low risk patient for venous thromboembolism, or what does it mean to be a high-risk patient? So we all need to be aware of that. You can make a poster, you can find one already, but really kind of ensuring, what does the nursing staff know, and what are those signs and symptoms that we really need to be thinking about when we're taking care of our patients. There are, very clear signs and symptoms when we think about for a DVT and a PE as well. So that apprehensions and feelings of impending doom, we see that for an AFE as well, right? So thinking about your patient, what are the risk factors? Where are they in their pregnancy and postpartum piece? And then what should we be paying attention to? And so I know this is a super busy slide, but I just wanted to kind of summarize some of the really great recommendations from CMQCC here. That number one, as much as we possibly can, we want our patients up and walking, right? I remember clearly after my third C-section that the tech came into the room, and I was like, I'm ready to get up. I want a shower. I want this Foley out. I'm ready to go do my walking. And she looked at me and she was like, it's not even been 8 hours since your C-section. I was like, I know, I'm ready to go. And she was like, this is not your first rodeo. And I said, no, ma'am, it's not. And I don't want to clot. So let's go. But we know that our patients aren't always able to advocate for themselves in that way. So what can we do to encourage that? And so from the nursing perspective, making sure that patients understand that they can be on some of these medications and still breastfeed. What foods should they avoid if they are on anticoagulant medications? What else they need to tell other providers? And then what's really important in that discharge education for the patient and family? What are signs and symptoms that they should be aware of so that they can either call EMS or call their provider and seek urgent care whenever needed? And so that brings me to the next piece, which is what is the patient education? So I know that I talked to you last time about all the urgent warning signs, and I 100% think that we need to give patients all of the warning signs, but this is keyed in just specifically for that VTE education. So number one, encouraging awareness. You are pregnant and you are postpartum, so that alone puts you at a higher risk for blood clots. A blood clot in your leg is called a DVT. A blood clot in your lungs can be life-threatening, or into your brain, and we need to make sure that they know how to advocate for themselves or get to the emergency room and call their providers, and really teaching what are symptom recognition. And so the great thing about the AIM urgent warning signs is that if you have the one symptom that pops up on the urgent warning signs that says I have extreme swelling in my leg, they can click on that and they can then get additional information that tells them, well, one leg is warmer than the other and it's tender to the touch, or it's it's hurting, then you should call your doctor. So I think that patient education, we're giving them so much information throughout their pregnancy. What resources then are we giving them to follow up when they go back home? What else are we telling their significant others who are with them? Because again, they are now taking care of themselves and a new baby or babies or other children. And managing all of that. So we know that our postpartum moms tend to put themselves at the bottom of the list, and we really need to make sure that they can advocate and recognize when there's a problem. So lots of different suggestions for teaching your patients. I know this is a really busy slide and I apologize for that, but you're going to get these. They're available for you, and you can also go to the CMQCC website. And then I have a few other resources for you as well at the end of the slide deck. And I think for me, it's always really important to encourage your patients to listen to their body and trust when they feel like something is wrong. And so we've heard multiple celebrities say that they had clots in the past and they knew something was wrong. They knew the signs and symptoms. And when they got brushed off, they were like, nope, you're going to listen to me, or, and you're going to keep going and really making sure that, something's not right. So get that second opinion and make sure that your patients understand that while we're all human, we need to make sure that you're telling us what you're feeling and what's going on. So if that's the biggest takeaway, is making sure your patients advocate for themselves. So there's a few really great patient resources. One is the Shane Foundation, and it has this really nice warning signs that are really specific to signs and symptoms related to VTE. And so I really thought this was a great website. There's also stories and patient advocacy through that website, so you could spend a little bit of time looking at that. There's all of the Stop the Clot. And I forgot about this resource until I was getting ready for this presentation, but Stop Clot is swelling in the leg, tenderness, leg cramps, out of breath, pass out, lightheaded, and then chest pain, and back pain when breathing, leg discoloration, overdrive, racing heart, and time, call help 911. And then there's also the Women in Blood Clots. So you can get to that through the National Blood Clot Alliance. So there's multiple resources, but it's a really beautiful, join the conversation, and it's specific for women who have given birth and increased risk for blood clots. So I really love this. And there's also some for those of us that take care of women at all ages of their lifespan, there's some menopause connections to Women in Blood Clots as well. And then the last little thing that I wanted to kind of add in is, what does ACOG say? So ACOG agrees with everything that we've already talked about. So there are two practice bulletins that have both been reaffirmed in 2025 for thromboembolism in pregnancy and inherited thrombophilias in pregnancy. And so really great recommendations on assessing risk factors as well as management. And then there are these two articles that I found yesterday, actually, as I was kind of wrapping up and making sure that I wasn't missing anything. And I'm going to start with the one that's kind of in the middle that says trends in antepartum delivery and postpartum VTE. Really kind of looking at that risk that has been analyzed over the last from 2009 to 2019, and it was a multi-state Medicaid database, and they really were looking at what were those obstetric related VTE risks, and that risk in general increased significantly over that study period from 2009 to 2019, and that then general risk for VTE related to comorbidities, related to our obesity, related to hypertensive disease. Then you add in the antepartum, peripartum and postpartum periods and delivery with vaginal delivery and cesarean delivery. So now you've got higher risk women coming into care. And so that, to me, I would recommend reading that article. There was a lot of great information in that. And then the last one was, I put it in, and you guys are probably going to read it and be like, they're talking about France. But, we always talk about how poor our birth outcomes are in South Carolina and in the US as developed nations, and we're at the bottom of the list all the time. But I thought it was interesting that with this study out of a different country came up with very similar kind of analysis of maternal mortality due to VTE and how important it was to make sure that risk assessment and appropriate management and anticoagulation in order to address the maternal deaths that are happening because of VTE. And so for this, it was really looking at how many women actually received prophylaxis. Of those women that received prophylaxis, was it appropriate prophylaxis? And then was there, what was the related pieces for the maternal death? And so I would recommend, if you haven't read that, and that just came out, I think, in March. I know it says volume 00, but it was, I believe, listed as March of 2026 for that article. So anyway, a couple of interesting reads if you want to check that out. Resources for you: the Safer Birth website, which is the AIM organization for safety bundles, CMQCC's website. For CMQCC, if you've never gone on there and you're trying to get some of the toolkits, you do have to register, but it is a free registration. But they will ask you what state you're from, what kind of work you do, are you inpatient, outpatient, etc. There's the Shane Foundation, the National Blood Clot Alliance, the Additional Women in Blood Clots. The American Society of Hematology also has some really great flyers for your patients who have known bleeding disorders and clotting disorders. And then the Foundation for Women and Girls with Blood Disorders had some also really, really great patient education tools. So I know as a provider in the office, I'm always looking for, where can I send my patients to get reliable, appropriate information that is not from TikTok, that is not medically based, that, where can we send them to? So there's some really great resources for you. And so that's what I've got today.